Did you know that you could be arrested and charged with impaired driving, even if you haven't had anything to drink or taken any unlawful substances? Imagine being pulled over and arrested for a DUI even though you've done absolutely nothing wrong. Now imagine being told that your license and your very freedom could all depend on an hour-long examination being conducted by one law enforcement officer who went through a 9-day course that's supposed to give him the ability to determine, scientifically, whether or not you were impaired by drugs. But that officer's subjective opinion could mean the difference between you going home and going to jail. And if you're one of the millions of American drivers that take a daily prescribed medication to treat a chronic physical or mental health condition, the mere fact that you took your medication as directed could form the entire basis for that officer's opinion, leading to losing your license and being charged with a crime. I'm Caraway. I'm a public defender and a criminal trial attorney, and today I'm going to talk to you about drug recognition officers, or as they call themselves, drug recognition experts.
Well, that's just like your opinion, man.
Despite the name, DREs are not nearly as scientific or as accurate as you might think. Now, when you picture an expert in drug recognition, what normally comes to mind? Maybe you're thinking about a doctor or a scientist or someone with years of training in pharmacology, maybe even someone with medical training, some sort of advanced degree. Well, unfortunately, you'd be wrong. A DRE does not have any advanced scientific or medical training. In fact, the name drug recognition expert is a name they gave themselves. Very basically, when police pull somebody over that they think might be impaired, but they can't find any evidence of alcohol use, they'll call in a DRE. So a DRE, put very simply, is a police officer who, in addition to the standard field sobriety training, is also trained to administer an evaluation as part of a program called the Drug Evaluation and Classification Program, or the DECP. The DEC program was created in the 80s and 90s by two sergeants in the Los Angeles Police Department to deal with what they saw as a growing epidemic of impaired drivers operating under the influence of substances other than alcohol. And in the late 80s, the National Highway Traffic Safety Administration, or NHTSA, created a standardized national curriculum. From the very beginning, this program has been created and maintained solely by law enforcement. No medical or scientific experts took any part in its creation. And despite not being created or sanctioned by anyone in the medical or scientific community, the DRE program claims that it can accurately determine whether a driver is impaired and able to operate a motor vehicle safely, whether that impairment is caused by a physical or medical concern, and what specific drug category that person is impaired by. Things that not even the best trained law enforcement officers are truly in a position to determine. So what kind of training do these DREs actually receive? Well, to answer that question, I've enlisted the help of my friend and former DRE, John Sandle. John?
Hi, I'm John Sandle. I'm a retired police officer, a former DRE, and now I'm a consultant and private investigator. The DRE training consists of 3 parts. The first part is a 16-hour preschool where the officers start to learn about the 7 drug categories and the 12-step process for the drug influence evaluation. The second part is a 56-hour course where they learn those things more in depth. The DREs are trained to use this to determine whether or not someone is impaired and by which drug category they're impaired by. One of the things that they teach you is that if you smoke marijuana, you will be able to see a green film on someone's tongue.
It makes no damn sense.
I know, and I agree with you, but according to the DRE training manual, it is. The third part is where they do 12 field evaluations on individuals, and they have to be the primary examiner on 6 of those 12 evaluations. To become certified, you need 3 of the 7 drug categories and have a 75% accuracy rate. You may be asking, how do they get certified with these field examinations? When I was certified, we would go to a concert venue and we would find people that actually were using drugs. We would see them using drugs, and we would do our evaluations on them. Now, most people go down to Jacksonville, Florida, and they do evaluations on individuals that are already in custody and do the evaluations on them, knowing that they've consumed some kind of drug. It's not like these evaluations are done on individuals that possibly could just have a medical impairment or no impairment whatsoever. These are individuals that are actually known to have consumed drugs.
What exactly does a DRE evaluation look like? Well, John and I will probably do a longer video on this at some point, but as a general rundown, a DRE will run someone accused of impaired driving through a 12-step process. The first of those steps is to rule out alcohol. That will usually involve a chemical breath test. The very second step is to talk to the arresting officer So before the DRE has even spoken to the person they're supposed to evaluate, they hear from the perspective of the person who already believes they're impaired. Not exactly scientifically unbiased. Then they speak to the suspect, and they ask them questions like, have you taken any drugs today? Are you on any medications? And they'll ask 6 questions that they call a medical rule-out. 6 questions to decide whether someone is impaired by drugs or experiencing one of the thousands of physical and mental health issues that can mimic symptoms of drug impairment. They'll look at someone's eyes, looking for signs of nystagmus or the inability to cross those eyes. And then they'll re-perform the roadside field sobriety tests. Now, it's important to remember that these field sobriety tests have been designed and validated for alcohol impairment only. There are literally hundreds of other drugs out there, and they all affect the body in a very different way. The same tools and techniques that we use to detect alcohol impairment do not work for other drugs. Next, they'll measure someone's pulse, blood pressure, and temperature. Then they'll do what's called a darkroom examination, where they will turn off the lights and measure someone's pupils in 3 different lighting conditions. And the way they scientifically measure that pupil area reaction is by using a highly calibrated device that they call a pupilometer. It's a laminated card with dots on it. They hold it up to someone's eyes and they estimate what someone's pupil sizes look like. And this is when things start to get a little weird, because the next step is examining muscle tone. Now, I should start by saying there really isn't a lot of scientific support for this part of the test. From the DRE manual, the DRE firmly grasps the upper arm and slowly moves down to determine muscle tone. The muscle should appear flaccid, normal, or rigid to the touch. Buy him dinner first? DRE will now check for injection sites and look inside oral and nasal cavities. And this is where they're looking for that green film on a tongue, which, again, if you've had any personal experience, you probably already know is not a thing. I mean, unless your weed is laced with green Jolly Ranchers. The DRE is then told to ask probing questions like, are you high? And finally, the toxicology exam, where someone will be asked to submit to a blood test. Now, the results of toxicology won't usually come for weeks later, so it's generally not part of the DRE's opinion. So that whole process takes maybe about an hour. After that, the DRE will record all of his evaluations on a face sheet, and they'll match all of that up to what's called a DRE symptomology matrix. Now again, this matrix was developed by law enforcement, and it makes certain assumptions based on 7 very broad categories of drug, which a lot of the times are a very large oversimplification of what the science actually says. And even at their very best, are only indicators of the possible presence of those drugs, and not of impairment by those drugs. Presence does not equal impairment. We'll explain why that's important later. It will then match these symptoms to the matrix, kind of bingo style, to determine what drug category or categories are likely causing impairment. So that's how a DRE comes to their expert opinion. It's mostly process of elimination and confirmation, and you don't need a scientific background to understand why it's so open to false positives and confirmation bias. Now, some of you might be thinking, isn't it better to have some tool to detect impaired driving than none at all? The answer to that is a lot more complicated than it seems.
Hi, my name is Dr. Anna Mattle. I am currently a practicing clinical pharmacologist at Dent Neurologic Institute with a Doctor of Pharmacy degree as well as a Master of Science in Pharmaceutical Sciences. I currently see patients for services including medication therapy management, investigator-initiated studies, and for multi-center clinical trials in my practice. So what are my thoughts on the DRE or on drug recognition evaluators? Unfortunately, DRE officers are simply not equipped with the robust knowledge that's required of drugs to be able to recognize the different effects that a single drug may have in different people. Well-meaning DRE officers are at risk of incorrectly opining that someone with a neurologic condition or taking therapeutic medications are impaired while driving. I see patients regularly in my practice who are diagnosed with neurologic conditions and they're taking medications for these conditions who would unfortunately fail the DRE officer exam despite not posing a driving risk. In scientific studies, the DRE process has not been shown to accurately discriminate between impaired and unimpaired drivers, to be able to discriminate between drug-induced impairment and impairment caused by medical conditions, or to be able to accurately identify the category of drug causing impairment. For more on this, be on the lookout for my pending book chapter co-authored with my fellow clinical pharmacologist, Dr. Fran Django.
So like Dr. Mattle just pointed out, the main concern with the DRE program isn't so much that a DRE can't determine when someone's impaired, it's that they're not always the best at identifying who isn't. At its core, the DRE is a confirmatory test, meaning that a DRE is only called in to confirm what police already believe, even when toxicology doesn't match a DRE's opinion. Say a DRE called a stimulant instead of a depressant. the DRE program still considers that a valid opinion. More alarmingly, if toxicology comes back entirely clean, meaning no substances in someone's system, the DRE program doesn't even necessarily consider that an incorrect call, claiming that it could be the toxicology that's misleading. Which begs the question, if a DRE can never be wrong, can they ever truly be right?
Being taken into custody, okay, for DUI drugs.
My name is Caitlin, and it happened to me.
It happened to me.
Well, I believe you have, okay? I need to borrow your arm real quick, okay?
It happened to me.
Innocent people arrested for driving on drugs.
It happened to me.
Our investigation shows this is not limited to one arrest or one officer.
I'm placing you under arrest for suspicion of DUI, less safe drugs, okay?
It's a nationwide phenomenon.
It happened to me.
It happened to me.
So you're saying that you don't smoke marijuana?
It happened to me.
It happened to me.
To me.
To me.
To me.
To me.
Do you understand what being arrested for DUI when you're sober, the impact it can have on somebody?
I don't. I wouldn't agree with sober. You're saying a person's sober. Clear tox does not necessarily exonerate a person beyond any shadow of a doubt.
Now look, the purpose of this video isn't to dunk on DREs. Drug-impaired driving is a very serious issue, and identifying and getting impaired drivers off the road is a difficult and important task. DRE officers are out there doing the best they can with what they have, and as a screening tool to help decide who might be impaired, there is nothing wrong with a lot of what the DRE does. But when they blanket that screening process with the appearance of scientific reliability that isn't there, and a level of infallible certainty that just isn't supported, innocent drivers pay the price. We all want safer roads, but it cannot come at the price of people that have done absolutely nothing wrong, losing their license, their livelihoods, and their very freedoms. And it cannot come at the price of further stigmatizing those with chronic physical or mental health issues, and would probably be far more unsafe drivers without them, having to decide whether taking those very medications is worth the risk of a possible criminal charge. If we want to keep dangerously impaired operators off the road in a fair and reliable way, then we need to start giving law enforcement better, evidence-based tools, and not doubling down on a scientifically unsupported procedure. Thanks for watching. Special thanks to John Sandle and Dr. Anna Mattle for their contributions to this video. To learn more about the DRE, or to suggest other video ideas, be sure to leave a comment below. And don't forget to like, subscribe, and share. For The Defense, I'm Del Caraway.